Hi everybody, welcome to our module on thyroid disorders. You can basically think of thyroid disorders as falling into one of three categories. There are those diseases that cause hyperthyroidism, there are those that cause hypothyroidism, and then finally there are disorders which cause thyroiditis. And the reason thyroiditis is its own category is because thyroiditis can cause either hyper or hypothyroid symptoms. The reason is as follows. When you initially develop inflammation of the thyroid gland, the thyroid hormone contained within the gland will spill into the plasma. This will cause the thyroid hormone levels in the plasma to begin to rise over time. However, eventually the inflammation will cause the thyroid gland to start producing less thyroid hormone. When this happens, the thyroid hormone level will start to fall, and eventually you can go all the way back down and become hypothyroid. So if this level in the middle of the screen is a euthyroid state, you can initially develop a hyperthyroid state, and that can be followed by a hypothyroid state, and both of these can result from thyroiditis. Therefore, the symptoms of thyroiditis depend to some degree on which phase of the disease you are in. The symptoms that result when a patient is hypothyroid all result from metabolism slowing down. So hypothyroid patients complain of lethargy and fatigue. They are often weak, and they may complain of dyspnea on exertion because they are so weak. They are often intolerant of the cold. Their metabolism is so slow that their body temperature actually can get low, and therefore if they go out into the cold, they are easily bothered by the cold and often complain of feeling cold all the time. They can have weight gain despite loss of appetite. Their metabolism has slowed, so even if they are eating less, they will put on weight. They're often constipated, and you can just think of this as more slowing down of the body. The bowels are beginning to slow down. The reflexes slow down. These patients will exhibit hyporeflexia on neurologic examination. Their skin is classically cool and dry, and they often have coarse, brittle hair. And then finally, patients who are hypothyroid can have bradycardia. And you can just remember everything slowing down. That's the easy way to remember all of these symptoms on the screen. Myxedema is a special skin finding in patients who are hypothyroid. It's also called thyroid dermopathy. It is non-pitting edema of the skin that occurs in hypothyroidism. The reason this occurs is because when patients are hypothyroid, hyaluronic acid deposits in the dermis. This is an osmotic agent, and it draws water out and leads to swelling. Usually the swelling is in the facial or periorbital area. However, there is a special form of myxedema called pretibial myxedema, which occurs over the shin. And this is seen in Graves' disease, which actually causes hyperthyroidism. We'll talk about this later. This can be a point of confusion for students because you can see pretibial myxedema in the hyperthyroid condition of Graves, but myxedema in general is something seen in hypothyroidism, and that usually occurs in the face or the periorbital region. You will also sometimes hear the term myxedema coma, and this is the term that is used when a patient develops coma from hypothyroidism. Here's a picture of a man with myxedema, and you can see this swelling around his eyes. That's the classic form of myxedema seen in hypothyroidism. Muscle symptoms are common among patients who are hypothyroid. This is called hypothyroid myopathy. As I told you before, hypothyroid patients are often weak. In addition, they can sometimes develop cramps and myalgias. And you should know, especially for step 1 and other board exams, that the creatinine kinase level can rise in patients who are hypothyroid. An increased serum CK level is found in up to 90% of hypothyroid patients, and it's a result of the low thyroid hormone levels. In addition to elevated levels of CK, you can also often see hyponatremia in patients who are hypothyroid. Hypothyroidism is a well-described cause of low sodium levels. The mechanism is believed to be increased secretion of ADH. This is an example of the SIADH syndrome, and the low levels of sodium are one of the factors that can lead to the confusion that is often seen in patients who are hypothyroid. Years ago, hypothyroidism could be fatal, but that's no longer the case because we have synthetic thyroid replacements available. The first one is called levothyroxine or Synthroid. This is a synthetic version of T4. The second one is called liothyronine or Cytomel. This is a synthetic version of T3. And you will almost never see Cytomel used any longer. Most of the patients who are hypothyroid that you will see on your clinical rotations will be taking Synthroid. The reason that Synthroid is preferred is for a couple of reasons. First of all, T3 is absorbed rapidly from the intestines, and this can cause mild hyperthyroid symptoms like tachycardia and tremor. In addition, as you know, T4 can be converted to T3 peripherally by the enzyme 5' deiodinase. Therefore, if you administer T4, you also replenish T3 levels. So for all of these reasons here, you will by and large only see people on Synthroid. You won't see patients taking Cytomel. And what you do is titrate the dose until the TSH is normal. When the TSH has returned to normal, you know that the patient is taking sufficient thyroid replacement therapy. Hyperthyroidism is basically the opposite of hypothyroidism. All the symptoms in hyperthyroidism occur from metabolism speeding up. So patients who are hyperthyroid are hyperactive. They have intolerance to heat. Their basal metabolic rate is high and they are always burning energy. This makes them warm and they feel very uncomfortable when they go into hot environments. They will have weight loss from all that extra metabolic activity, even though their appetite may be increased. Their bowels move more rapidly, so they have diarrhea. Their reflexes are more rapid, so they have hyperreflexia. Their skin is warm and often moist. They classically have fine hair, and they can develop tachycardia, and in particular, they can sometimes go into an arrhythmia called atrial fibrillation. And when patients present with new onset atrial fibrillation, one of the things you always need to do is exclude a hyperthyroid state. Thyroid storm is a life-threatening version of hyperthyroidism. It's often called thyrotoxicosis. It's usually precipitated by some type of acute event. So it's a patient who has pre-existing hyperthyroid disease. They may have Graves or toxic multinodular goiter. We'll talk about these later. They then have surgery or have a trauma or develop an infection, and this triggers a rise in thyroid hormone production, and as a result, they get dangerously sick and they develop thyroid storm. The reason they get very sick is because there is a massive catecholamine surge. These patients can develop a fever and delirium. They can develop tachycardia, and in particular, they often die from arrhythmias from the catecholamine surge. They often have hyperglycemia. This is because the catecholamines raise the plasma glucose. Thyroid hormone can also raise the plasma glucose, and they also sometimes develop hypercalcemia from high turnover of bones. A goiter is an enlarged thyroid. This is a picture on the screen of a woman with a massive goiter, and this is what occurs when you have high levels of TSH but inability to produce T3 or T4 for any reason. The TSH will continue to stimulate growth of the thyroid, but it does not result in rising levels of T3 or T4. As a result, the pituitary makes more TSH and it creates a vicious cycle until the thyroid gland can become enormous. This is commonly seen in third world countries when people don't eat enough iodine. Their TSH level gets very high, but they don't make thyroid hormone, and as a result, they get a huge goiter in their neck. You can also see a goiter in patients who have thyroid stimulating antibodies. This occurs in Graves' disease. We'll talk about this in a few slides. When you suspect that a patient may have a thyroid disorder, the best initial test is always a TSH, and I've written that in big letters on the screen to remind you of this. This is a classic trick question for medical students. You don't want to answer that the best initial test in a suspected thyroid disorder is the plasma T3 or T4. The reason those tests are not preferred is because they can fluctuate, and the TSH is actually testing what the tissue level is seeing in terms of thyroid hormone, so it's much more sensitive to changes in thyroid hormone function. And in fact, the TSH can become abnormal before the T3, T4 levels in the serum begin to rise or fall. So it is the most sensitive test, and it's always the best initial test in thyroid disorders. Most thyroid disorders are called primary thyroid disorders. This means the problem is related to the thyroid gland itself. If you look at this picture on the screen, in most thyroid disorders, the thyroid gland is either overproducing or underproducing thyroid hormone, and the pituitary gland is modifying the TSH level in order to try and correct the problem. This means that the TSH level will always be opposite the thyroid hormone, so that when the patient is hypothyroid, there will be a high TSH level with low T3, T4. The reason for the high TSH level is because the pituitary gland is trying to correct the thyroid disorder. In hyperthyroidism, that is a primary disease, there will be a low TSH, and that's because the anterior pituitary gland is trying to also correct the problem by lowering the TSH level. Rarely you will encounter patients who have what is known as central thyroid disease. This is where the thyroid gland is normal, but the problem is that the pituitary gland is over-secreting or under-secreting TSH. Central thyroid disease is much less common than primary thyroid disease, and in central thyroid disease you will see a low TSH coupled with low T3, T4 levels, or a high TSH coupled with high T3 or T4 levels. These are all rare disorders that affect the pituitary or the hypothalamus in some way. Usually these disorders are caused by hypothalamic pituitary axis tumors. The tumors sometimes block the secretion of TRH or TSH, and this leads to central hypothyroidism. Rarely the tumors produce TSH. These are called TSH-omas, and this can lead to central hyperthyroidism. And then finally, there's a rare disorder called pituitary resistance to thyroid hormone. This is where the pituitary does not sense thyroid hormone, and it is not subjected to the normal negative feedback of thyroid hormone. Thus, it constantly overproduces TSH, and this leads to hyperthyroidism. Rarely you can see disorders that are called central thyroid disorders. In these disorders, the thyroid gland is working fine, but the pituitary gland is overproducing or underproducing TSH. In these disorders, which are much less common than primary thyroid disorders, you will see a low TSH along with low thyroid hormone levels, or a high TSH along with high thyroid hormone levels. These disorders all involve the pituitary and the hypothalamus. Most of them involve tumors of the hypothalamic pituitary axis. Sometimes those tumors block the secretion of TRH or TSH. This can cause hypothyroidism. Rarely the tumors can produce TSH. These are called TSH-omas, and that can lead to hyperthyroidism. And then there's also a syndrome where the pituitary is resistant to the negative feedback of thyroid hormone levels. This means that the pituitary will oversecrete TSH, and this can lead to hypothyroidism. They're unlikely to ask you to diagnose these on step 1, but they may want you to understand the difference between central and primary thyroid disorders, and make sure you recognize that in order to sort those out, you need to look at the TSH level in parallel with the thyroid hormone levels. Reverse T3 is a blood test that is sometimes used to work up certain thyroid disorders. Reverse T3 is an isomer of T3. It is also derived from T4, just like T3. So on the left side of the screen is the structure of thyroxine. It can be used to form T3, as you know, but it can also form reverse T3, which has the same atomic makeup, but the molecules are put together differently. Therefore, it's an isomer of T3. The levels of reverse T3 in the plasma usually parallel the level of T4. So when there's low T4, there is also low reverse T3. The one exception to that is something called the euthyroid sick syndrome. In patients who are critically ill, they can develop a low TSH related to their critical illness. It is not due to a central or primary problem with the thyroid gland. This will lead to slightly low T3 and T4 levels, and this can look just like central hypothyroidism. It can have the same blood test pattern that we saw in those patients who had tumors of the pituitary or the hypothalamus. The one difference is that reverse T3 rises in critical illness. Its clearance is impaired. Therefore, if you have a critically ill patient who has a low TSH and T4 and T3, you can check the reverse T3. If it is also low, then that patient has central hypothyroidism and you need to look for some type of central nervous system tumor. If the reverse T3 is high, then that patient has the sick euthyroid syndrome, and you can just treat the critical illness and the sick euthyroid syndrome will go away. Now I'm going to talk about specific diseases that cause hyperthyroidism, and the most common is Graves'. Most of the patients you will see clinically who have hyperthyroidism have Graves' disease. However, you can also get hyperthyroidism from all of these items I've listed on the screen here. We'll go through all of them in the next few slides. And don't forget what I told you before, early thyroiditis can lead to hyperthyroidism. Most forms of thyroiditis ultimately present as hypothyroidism late in the course of the disease, but early, as I said before, they can have hyperthyroid symptoms. Graves' disease is an autoimmune disease in which thyroid-stimulating antibodies are produced. Basically, antibodies are produced that function the same way as TSH. So the thyroid gland behaves as if it is being saturated with TSH, but in fact the TSH levels are not elevated, and as a result, symptoms of hyperthyroidism occur. The way you can recognize Graves' disease clinically, and especially in board questions, is by looking for the presence of two unique clinical signs that only occur in Graves' disease. So patients with Graves will have symptoms of hyperthyroidism, but in addition, they commonly have symptoms in their eyes and in their shins. In the eyes, they have a condition known as exophthalmos, which is bulging of the eyes. There will be proptosis, which means protrusion of the eye, and also periorbital edema. Often there are no eye symptoms, but the patient notices the bulging of the eyes. In the shins, there will be pretibial myxedema, which we talked about before. This is non-pitting edema of the shins. The reason for these two findings, which are unique to Graves' disease, has little to do with the high levels of thyroid hormone. It's got to do with T-cell lymphocyte activation of fibroblasts. The activated fibroblasts contain the TSH receptor, and they become active in the setting of the TSH-stimulating antibodies. The stimulation leads to secretion of glycosaminoglycans, and this mechanism is high yield to remember for your boards. Glycosaminoglycans are hydrophilic substances. They're mostly hyaluronic acid, and they draw in water, and this leads to swelling, and that's why you get swelling around the eye. It's also why you get swelling around the shins. This is a picture of what some of the findings of Graves' disease can look like. On the left is a picture of exophthalmos. You can Google this and find many examples of this. On the right is a picture of the pretibial myxedema over the shins. The diagnosis of Graves' disease is usually made when the patient is hyperthyroid by their lab tests. They have a low TSH level and high levels of thyroid hormone in the plasma, in addition to exophthalmos or myxedema, those unique findings of Graves. You can also measure the level of TSH receptor antibodies. These are sometimes called thyroid-stimulating immunoglobulins, and when these are increased, that suggests a diagnosis of Graves. The treatment involves treating the symptoms at first. This is usually done with beta blockers to blunt the symptoms of hyperthyroidism, and then drugs called thionamides, which we'll talk about in a minute, which inhibit the formation of thyroid hormone. These drugs are usually given initially just to make the patient feel better, but then they are referred for definitive therapy, and the definitive therapy usually involves either ablating the thyroid gland with radioactive iodine or surgery to remove the thyroid gland. When you eliminate the thyroid, then the stimulating immunoglobulins can't exert their effect anymore, and the patient can take thyroid replacement therapy for the rest of their life. The two thionamide drugs are called methimazole and propethiouracil, or PTU. Methimazole inhibits thyroid peroxidase. This will blunt the organification of iodine and also blunt the coupling of MIT and DIT. In the thyroid physiology module, I talk more about all the multiple functions of TPO. Propethiouracil also inhibits TPO, but in addition, it inhibits the enzyme 5' deiodinase, and this blunts the peripheral conversion of T4 into the more potent T3. Both of these drugs can cause a skin rash. This is a common side effect. The feared side effect of these drugs is a rare complication called agranulocytosis. This happens to a small number of patients on these drugs. They develop a drop in white blood cell count. This may present as fever or infection after starting the drug, especially on a board exam question. The white blood count will be very low, but it will improve with stopping the drug. And in rare cases, there have been reports of aplastic anemia developing from prolonged exposure to these drugs. And this is another reason why the definitive therapy is ablation of the thyroid gland, not taking these drugs for indefinite periods of time. Both of these drugs are also associated with hepatotoxicity. And then finally, methimazole is a teratogen. Treatment of hyperthyroidism in pregnancy is a very complex topic. You don't want to expose mothers and babies to administration of these drugs, but in addition, radioactive iodine ablation is contraindicated and surgery during pregnancy carries risk. If you do use methimazole, it is associated with congenital malformations, especially in the first trimester, and for this reason, PTU is often used during early pregnancy in women who are hyperthyroid. If patients present in thyroid storm from Graves' disease or in thyroid storm from an unknown cause, there are some special treatments that are often used. First of all, propranolol is often the beta blocker of choice in this situation, and that's because propranolol can block the conversion of T4 to the more potent T3. It is a weak inhibitor of the 5' deiodinase enzyme. Thionamides are also used. These are drugs like PTU and methimazole, which we talked about in the last few slides. SSKI is often administered in thyroid storm. SSKI stands for saturated solution of potassium iodide. It's an iodide load, and this will shut down T4 production from the thyroid via the Wolff-Chaikoff effect. And then finally, steroids are often used in cases of thyroid storm. They've been shown to reduce T4 to T3 conversion. In addition, they will suppress any autoimmune processes going on in the thyroid, such as Graves' disease. And then finally, sometimes patients who have thyroid storm will deplete the cortisol in their adrenal gland, and they will become adrenally insufficient. So by administering steroids, you treat any possible concomitant adrenal insufficiency. The eye involvement of Graves' disease is sometimes referred to as Graves' ophthalmopathy, and the reason it's referred to separately is because it sometimes follows its own course from the thyroid gland. Often the eye symptoms do not improve when you treat the hyperthyroidism, and sometimes they even worsen despite treating the hyperthyroidism. So patients who have Graves, even though their thyroid symptoms may get better with therapy, can have chronic eye symptoms, and that's Graves' ophthalmopathy. Patients with Graves sometimes suffer from chronic irritation or excessive tearing or pain of the eyes. Sometimes the eye symptoms are worsened by exposure to cold air or wind, and sometimes bright lights bother patients who have Graves. If the eye symptoms are severe, they are sometimes treated with special therapies to target the inflammation. Remember, the eye involvement is related to lymphocytes and inflammation, so you can treat it sometimes in severe cases with steroids. Sometimes radiation is used, and rarely surgery is necessary to treat the Graves' disease eye involvement. Toxic adenomas are nodules in the thyroid that function independently. Usually they have tissue that contains a mutated TSH receptor. As a result, they do not respond to TSH, and they independently produce thyroid hormone. Patients who have one nodule are said to have a toxic adenoma. Patients who have multiple nodules are said to have toxic multinodular goiter. The findings of toxic adenomas are a palpable nodule, obviously, and then hyperthyroidism symptoms and lab findings. You can treat these with surgery, of course, to remove the nodule, but you also can administer high dosages of radioactive iodine. This will ablate the thyroid, but also ablate the nodules, and then the patient can take thyroid replacement hormone for the rest of their life. In addition to being used as a therapy for toxic adenomas, radioactive iodine is also useful for workup of thyroid nodules. The concern anytime you detect a thyroid nodule is that it may be a toxic adenoma, but it may also be a cancer, and you can use radioactive iodine to help sort that out. The way you do this is you administer a small dose of iodine 131. It's usually given orally as a pill. This is a much lower dose than is used for ablation. Obviously, this is contraindicated in pregnancy or breastfeeding because you don't want to expose the baby to radioactive iodine. That radioactive iodine will be taken up by the thyroid, and you can take a picture of the radiation that it is emitting. If the nodule you are evaluating is hot, meaning it takes up lots of the iodine 131, this usually means it's not cancerous. Toxic adenomas, as we said on the last slide, are producing lots of thyroid hormone. They are functioning independently of TSH, so they will take up lots of the iodine 131 to put it into thyroid hormone. They will appear as a hot nodule on imaging. Cold nodules, on the other hand, may be cancer. There's about a 5% chance of cancer in cold nodules because many cancers do not take up iodine. So when you find a cold nodule, you have an increased worry that that nodule may be cancerous, and these are often biopsied with fine needle aspiration to look for cancer cells. Moving on, let's talk about other causes of hyperthyroidism, and I'll start by talking about the Yod-Basedow phenomena. This is iodine-induced hyperthyroidism. This often occurs in regions of the globe where patients are chronically iodine deficient. If you introduce iodine into the diet, some patients will develop hyperthyroidism. Many of these patients probably have toxic adenomas, and when you introduce iodine into the diet, those adenomas begin overproducing thyroid hormone. You can sometimes see this in other parts of the world when patients have a toxic adenoma and they suddenly get a large dose of iodine. So for example, if a patient has a toxic adenoma and you administer a drug with a high iodine content like amiodarone, or if you give them an expectorant for their cough, some of these contain potassium iodide. In addition, contrast dye used for CAT scans also contains lots of iodine. So if you administer any of these things to patients who have a toxic adenoma, the toxic adenoma can suddenly produce an excessive amount of thyroid hormone and the patient can develop hyperthyroidism. So that's a nice segue into the drug amiodarone, which we'll talk about now. This is the structure of amiodarone on the screen. It's an antiarrhythmic drug used for patients with atrial fibrillation and sometimes ventricular fibrillation. Note that it has two iodine molecules in its structure, and if you forget that, the letters IOD are in the name of the drug. And it can cause hyperthyroidism by two mechanisms. The first type is called type 1 amiodarone-induced hyperthyroidism. This occurs in patients who have pre-existing thyroid disease. So for example, if patients have a history of Graves' disease or multinodular goiter and they are administered amiodarone, the amiodarone will deliver excess iodine to their thyroid gland, and this will lead to hyperthyroidism. The type 2 hyperthyroidism that occurs in amiodarone is a destructive thyroiditis. It's inflammation of the thyroid gland. This leads to excessive release of preformed T4 and T3. There's no increase in hormone synthesis. This is a direct toxic effect of the drug, and this type of hyperthyroidism occurs in patients without pre-existing thyroid illness. Now we're going to move away from hyperthyroidism and talk about hypothyroidism. All of the items shown on the screen here can cause hypothyroidism, and we'll talk about each of them in the next few slides. Note that amiodarone can cause hypothyroidism in addition to hyperthyroidism. We'll talk about why in a minute. Note also that I've listed the causes of thyroiditis on this slide. As I told you before, thyroiditis can initially cause hyperthyroidism, but eventually it always leads to hypothyroidism. And in fact, the most common cause of hypothyroidism is Hashimoto's in parts of the world where there's enough iodine in the diet. Iodine deficiency is sometimes called endemic goiter. This is goiter that occurs in regions of the world with widespread iodine deficiency. It's common in mountainous areas. The water runoff from the mountains pulls iodine with it, and it depletes iodine from the soil and the water, and therefore patients are more susceptible to iodine deficiency. The constant elevation of TSH trying to stimulate more production of thyroid hormone leads to an enlarged thyroid. And this is a picture of a woman with a severe iodine deficiency on the screen. You can see she has a massive goiter in her neck. She's not consuming enough iodine to make thyroid hormone, and the pituitary is constantly stimulating her thyroid gland, making it bigger and bigger. Iodine excess can also lead to hypothyroidism via the Wolff-Chaikoff effect. Excessive iodine in the diet could lead to hyperthyroidism, but the body has developed a way to protect itself, and that's called the Wolff-Chaikoff effect. When there's excess iodine in the diet, this inhibits organification, so there is less synthesis of MIT and DIT in the thyroid gland. What this means from a clinical perspective is that patients who have chronic high iodine intake can develop goiter or hypothyroidism. So let's pause here and review all the ways that iodine can affect the thyroid. If you are deficient in iodine, you can develop hypothyroidism and endemic goiter. If you have excessive iodine in your diet, you can also develop hypothyroidism via the Wolff-Chaikoff effect. And then I mentioned before during our discussion of hyperthyroidism that if you have a toxic adenoma and you are exposed to a load of iodine, you can develop hyperthyroidism as well. Make sure you understand these three different mechanisms of thyroid disorders caused by iodine in the diet. A goitrogen is a substance that inhibits thyroid hormone production. The most common is iodine via the Wolff-Chaikoff effect. However, there are others. One of them that is high yield for you to know for step one is lithium. Lithium is a drug used in psychiatry. It inhibits the release of thyroid hormone and can lead to hypothyroidism. There are also certain foods that have goitrogen effects. Cassava is a plant, millet is a type of grass. Some people consume large amounts of these in their diet and they can potentially develop hypothyroidism. If you Google the term goitrogen, you will find numerous substances that are reported to have an impact on the thyroid. Now let's talk about amiodarone again. As we mentioned a few slides ago, it can cause hyperthyroidism via two mechanisms, but it can also cause hypothyroidism. The excess iodine present in the amiodarone molecule can lead to hypothyroidism via the Wolff-Chaikoff effect. This suppresses thyroid hormone synthesis. Now, normally, patients will escape this effect in a few weeks and their thyroid function will come back to normal. However, patients who have pre-existing subclinical thyroid disease develop what's known as failure to escape, and they essentially never bounce back from the Wolff-Chaikoff effect and they remain permanently hypothyroid after administration of amiodarone. A second mechanism by which amiodarone can affect thyroid hormone levels is because it can mimic T4. This means it will inhibit 5' deiodinase, which is found in peripheral tissues, and this will blunt the conversion of T4 into the more potent T3. So let's review all the different ways amiodarone can affect the thyroid gland. First of all, it can cause hypothyroidism by two mechanisms. It can lead to iodine excess from the iodine contained in the amiodarone molecules. This can lead to hypothyroidism via the Wolff-Chaikoff effect. In addition, amiodarone inhibits 5' deiodinase, and this can lead to hypothyroidism by blunting the peripheral conversion of T4 to the more potent T3. There are also two mechanisms by which amiodarone can cause hyperthyroidism. It represents an iodine load, and this can lead to hyperthyroidism in patients who have adenomas. And as I said before, it can also cause thyroiditis. So I've written a very important point at the top of the screen here, which is that you always need to check a TSH before starting any patient on amiodarone. You need to establish the baseline so that you can use it for comparison if the patient develops thyroid symptoms later. Congenital hypothyroidism occurs when babies are born or children grow up without a normally functioning thyroid gland. You need thyroid hormone for normal bone growth and CNS maturation, so children who develop in a hypothyroid state can develop a severe syndrome known as cretinism. These children have stunted growth and mental retardation. This happens in the third world when children grow up in areas where iodine is deficient in the diet. It can also happen if children are born without a normally functioning thyroid gland. Sometimes the thyroid gland does not develop normally. This is called thyroid dysgenesis. And then finally, there are rare inborn errors of thyroid hormone synthesis. These are called dyshormonogenesis syndromes. And the most common one is abnormal development of the TPO enzyme. You need a normally functioning thyroid peroxidase enzyme in order to make thyroid hormone. And if you don't have normal TPO, then the child will be hypothyroid and they can go on to develop cretinism. Cretinism is the most common treatable cause of mental retardation. Most causes of mental retardation are not treatable, but if you identify hypothyroidism in a baby, you can treat it from birth and the child will never develop the symptoms of mental retardation. For this reason, most states and countries have newborn screening programs in place where they measure a T4 level or a TSH from a heel stick blood sample on newborn babies. This is a picture on the screen of a child with cretinism. They have mental retardation, as I mentioned. They have coarse facial features like the child in the picture, as well as short stature. And then two classic findings of congenital or childhood hypothyroidism are presence of an umbilical hernia, as is shown in the picture, and also an enlarged tongue, as is shown in the picture. Many of the patients you'll see clinically are on thyroid replacement therapy to treat iatrogenic hypothyroidism. This is thyroidism that we caused on purpose. This can happen as a result of thyroid surgery, which is often done for Graves' disease or to treat malignancy. It's sometimes the result of radioactive iodine therapy. As I mentioned before, you can administer iodine 131 as a solution or capsule, and the beta emission radiation will damage the tissue, and this will ablate the thyroid function over a few weeks. And this is a therapy that is often done for Graves or sometimes thyroid cancers. And then finally, many patients have received neck radiation either for Hodgkin's lymphoma or head and neck cancer, and this will destroy the thyroid gland and make them hypothyroid, and they will need to go on thyroid replacement therapy. I'll finish this module by talking about the causes of thyroiditis. As I told you before, thyroiditis can initially cause a transient period of hyperthyroidism followed by hypothyroidism. In clinical practice, most forms of thyroiditis present with hypothyroidism. However, you need to know, especially for step 1, that they can initially cause hyperthyroidism early in the course of the disease. I'll begin by talking about Hashimoto's thyroiditis, which is also called chronic autoimmune thyroiditis, and this is the most common cause of hypothyroidism in parts of the world where people get enough iodine in their diet. In Hashimoto's thyroiditis, lymphocytes infiltrate the thyroid gland. It's an autoimmune disorder. There is T-cell attack of the thyroid with B-cell activation, and it is associated with HLA-DR5. The stimulation of B cells leads to the production of antibodies. They're not involved in the pathophysiology of the disease, but you can measure their levels in the serum for diagnosis. So you can find antibodies to TPO and thyroglobulin in patients with Hashimoto's. If you biopsy the thyroid gland, what you will see on histology is a massive infiltrate of lymphocytes in the thyroid tissue. That should make sense to you if you understand that lymphocytes are responsible for the pathophysiology. Sometimes there are so many lymphocytes present that they form germinal centers. And then a second classic finding of Hashimoto's thyroiditis is the presence of Hürthle cells. These are enlarged follicular cells with eosinophilic cytoplasm. Just like most autoimmune disorders, this occurs primarily in women. They develop an enlarged, non-tender thyroid gland. Gradually, over time, they lose thyroid function, and this leads to symptoms of hypothyroidism, and that's how Hashimoto's usually presents, with signs and symptoms of hypothyroidism. If you do a workup, you will find lab findings consistent with hypothyroidism like we talked about before. The treatment is to replace the thyroid hormone with synthetic thyroid hormone, and you need to know that people who have this condition have an increased risk of non-Hodgkin's B-cell lymphoma. If you understand that lymphocytes are involved in the disorder, then it's easy to remember that it can potentially lead to lymphoma. Subacute thyroiditis is also known as de Quervain's thyroiditis or granulomatous thyroiditis, and the most important thing to know about this condition for step 1 is that it involves granulomatous inflammation of the thyroid gland. So on biopsy, you will see the presence of granulomas and giant cells. It occurs in young females, and they usually present with symptoms of pain in the neck because they develop a tender and large thyroid gland. And I've bolded the word tender because it's relatively unique. Most of these thyroid disorders do not present with a tender thyroid gland. Just like in all forms of thyroiditis, they will develop hyperthyroidism followed by euthyroid state followed by hypothyroid state. However, the thyroid symptoms are usually mild, and it's often the neck symptoms that bring them to medical attention. The treatment is with anti-inflammatories like aspirin or NSAIDs or sometimes steroids. Usually the thyroid symptoms are mild, as I said before, and they don't often require treatment, and this condition usually resolves in a few weeks and is self-limited. Rydell's thyroiditis is a rare condition that involves fibroblast activation and proliferation, and the key word here is fibroblast, which leads to fibrous tissue and collagen deposition in the thyroid. That's the key pathophysiology feature of this disorder. This leads to what's known as a rock-hard thyroid. That is a buzzword for the USMLE for Rydell's. Another reason they like to ask you about this rare condition on the boards is because the disease process often extends beyond the thyroid, so they can use this as a way to test your knowledge of neck anatomy. So it can involve the parathyroid glands, which, as you know, are right next to the thyroid. This can lead to symptoms of hypoparathyroidism. It can involve the recurrent laryngeal nerves and lead to hoarseness. It can compress the trachea and lead to difficulty breathing. And you should know that this condition is associated with IgG4 plasma cells. There are a number of so-called IgG4 related diseases. They're all rare. Another one is autoimmune pancreatitis, and this is considered one of the potential IgG4 related diseases. You can often see IgG4 plasma cells in biopsy specimens. The last disorder I'll mention is called lymphocytic thyroiditis or painless thyroiditis. This is a variant of Hashimoto's thyroiditis, and just like Hashimoto's, it involves lymphocytes infiltrating the thyroid gland. This can cause a brief period of hyperthyroidism that sometimes is brought to clinical attention, and it can look like the patient might have Graves, except there will be no eye or skin findings, and the thyroid stimulating immunoglobulin levels will not be elevated. Following the hyperthyroidism, as we have discussed, the patient can develop symptoms of hypothyroidism, and this can look like Hashimoto's. However, Hashimoto's, remember, is also called chronic thyroiditis. This is not a chronic condition. It's usually self-limited and goes away in a few weeks. So if it goes away in a few weeks, it's called painless thyroiditis. If it persists, the patient probably has Hashimoto's. And that concludes our module on thyroid disorders.